GBS is in page 2103. Please pronounce this the way it's supposed to be pronounced, which is the French way. So don't say Guillain-Barré, it's Guillain-Barré. Okay, Guillain-Barré. It's just like, any other French word like ménage à trois. Okay. So what is it? Acute idiopathic polyneuritis. Now it's a mouthful. So it's basically an autoimmune disorder. Now, how do you get it? It's usually preceded by some flu infection. In fact, because the flu vaccine is a live vaccine, correct? Yes? Yeah. So when after getting a flu vaccine, there's a chance you may develop Guillain-Barré syndrome as well. Okay? Because most patients that we see who have this, when we do the HPI, history of present illness, there's a some form of viral infection. Doesn't necessarily is restricted to flu. The patient suffered a viral event approximately 2 weeks before the onset of symptoms. It includes again the flu vaccination, because the flu vaccine is a live vaccine. So the manifestation, so what happens really here is rapid segmental demyelination of the peripheral nerves, meaning it's segmental demyelination. So not the entire, this is not the same as multiple sclerosis. This one will only affect certain parts of the peripheral nerves. Now the manifestations, the pattern is always ascending paralysis, ascending weakness and paralysis. And it's always symmetrical, meaning it's both feet, both legs, both thighs, both everything. Ascending, the pattern of weakness is ascending. So most stories go when we look at the history, the patient says, "Oh, I just got up one morning, dangled in bed, and then when I got up, I fell because I had no strength in my legs." It occurs that fast. We had the same thing happen. We had an instructor here before. I think it was 2016 or maybe 2015. She developed GBS. She had GBS after exactly she had the flu also 2 weeks prior, and she eventually went into disability because she develops another type of polyneuritis after the GBS. The GBS was confirmed because she did respond to the treatment, just like the textbook says she will. But then a few months later during rehab, she deteriorated. Okay, so now she's permanently in a wheelchair. Okay? But it's not GBS anymore. She developed something else, a freak complication. But they couldn't blame it from GBS though, because it's not known to do that. So ascending weakness and paralysis, hyporeflexia, and paresthesias. Okay. Now, the pattern again is if the patient does not seek treatment, and the patient will receive one of two treatments recommended here to shorten and therefore hasten the recovery of the patient. It has to be done within 2 weeks because otherwise the patient will probably be permanently disabled. If not, they could die from this as well if not treated. These are the other known precipitating events: a Campylobacter jejuni infection, cytomegalovirus, Epstein-Barr virus. So here's the flu, and then the Zika virus was added as well. So these are the precipitating events, meaning some infection occurred, and then 2 weeks approximately after that infection, then the patient developed symptoms of GBS. There's different types of GBS, but we'll stick with the most common, which is the ascending weakness and paralysis type. So it's not very common. Look at the cases, 1 to 2 cases per 100,000 people. It's not a lot at all. Okay, so that's, but it adds up though. So if we add how many Americans are there? There are 330 million Americans, right? So it does add up. Okay, so there's quite a lot if you take it collectively. So as mentioned earlier, death will occur usually from complications of immobility. So if the patient doesn't die from respiratory failure, they'll die from a PE due to a blood clot. All complications from immobility. So I won't test you on the pathophysiology. Again, it's autoimmune. The condition is precipitated by some viral event approximately 2 weeks prior. Here are your manifestations. It begins, again, it's the symptoms onset is acute. There's muscle weakness from the lower extremities first, and then it goes up. By up, meaning it goes from the feet to the leg, to the thigh, to the pelvis, and then eventually it affects the diaphragm. So that's what causes the respiratory muscle paralysis. And then the patient goes on a ventilator. So to prevent the need for mechanical ventilation, so the patient needs to receive one of two treatments. Okay, already mentioned here, GBS progresses to peak severity within 2 weeks and no longer than 4 weeks. So this is the peak of the manifestations. Here's to diagnose, there's really no definite diagnostic test to say that it's GBS. All we can do is rule out other possible causes. So they'll do EMGs, a spinal nerve test to see, is this a spinal cord stenosis problem, or is this some meningitis problems, because they mimic the manifestations. And we just try to rule out other causes. And then once we've ruled out other causes, then the doctor arrives at a GBS diagnosis. Treatment, because again of the rapid progression, so time is important here. So the patient must seek medical intervention within 2 weeks of the presentation. Those who wait later usually end up on the ventilator because we cannot arrest the development of the paralysis, and it quickly moves up and affects and paralyzes the diaphragm. Therefore, patient gets intubated, and once that happens, then we cannot reverse it anymore. Okay, so the patient will just wait until the event stops, which is again complicated by the consequences of being on a vent, which is what will happen to you if you're on a ventilator: pneumonia, and then sepsis, etc. And then once you're paralyzed, also we got DVTs, we've got pressure ulcers. Okay. So here's our two treatments to arrest the progression. These two has to be done within 2 weeks again from the onset of symptoms. So patients who usually miss the 2 weeks are obviously patients who are either uneducated or uninsured. Because what will you do if you have no insurance? Are you gonna run at the first sign of this to the ER? Okay, so if you've never had experience being uninsured, you won't know how that feels. Okay, so we're lucky. Most of us here have insurance, so we can afford to seek help. It's only one of the two. Okay, that really doesn't make sense getting both unless you pay for it. But again, it's useless if you do both. So you either get plasma exchange. Why plasma exchange? This is plasmapheresis. Same thing we did for the myasthenia gravis patient last semester. Hey, this is an antibody problem. It's an autoimmune disorder. So if we treat you with this, then we remove the autoantibodies, replace it with good antibodies from somebody else. IVIG will do the same thing. IVIG, though, is cheaper compared to plasma exchange. Plasma exchange is more of a hassle because you'll have to do like dialysis. So you'll have several treatments every week for a few weeks, whereas IVIG, well, you just have a few infusions. Okay? Because IVIG is the antibodies already. So this is just a infusion. IVIG is very expensive though, because the solution, the antibodies, the plasma used here is sold per gram, meaning this unlike plasma wherein it contains the protein, the clotting factors, and the water, IVIG is pure antibodies. So it's more expensive and it's sold by the gram. It's about 15, last time I checked, which was over 5 years ago, it's about $1,500 per gram. And the dosing is by weight. So one treatment can easily be, one infusion can cost probably $30,000. And it's not one treatment. Okay? It's several treatments, so that can easily top $1 million. Okay, just for the IVIG alone, not counting doctor's fees, consultation fees, admission, etc. And questions, of course, will be including plasma exchange, because most patients opt for plasma exchange because that's the cheaper option. So please review plasmapheresis from the myasthenia gravis chapter, because that's where we found nursing responsibilities for plasma exchange or plasmapheresis. And the rest of these are your nursing care for someone who has respiratory problems, who are bedbound. So there's respiratory support. For the other conditions, because it doesn't stop at the diaphragm, it will ascend further. Although the good thing is it doesn't affect cardiac function, because this will only affect skeletal muscles, not cardiac muscles. So there won't be any cardiac issues here unless it occurs as a result of mechanical ventilation. So others here is when we say bulbar weakness, bulbar muscles are those that are involved in chewing, swallowing, and speaking. So the muscles in your face and your neck, they are called the bulbar muscles. So when they're affected, then the patient will have to have a feeding tube, either through nasogastric tubes or a PEG tube. Physical therapy will help, especially with DVT and PE prevention. Nutrition, like I said, because chewing will be impossible here once the bulbar muscles are affected. As well as communication. Again, speaking, swallowing, chewing muscles are affected. And this is scary, yeah? Because this can affect any age. Does not really discriminate. Again, the only preceding event is some viral infection, which were enumerated already earlier. And there's fatigue, obviously, unless the patient's already paralyzed. That's about it. Any questions on GBS?
The other place that we use the IVI, I said that was for myasthenia gravis. We use that for rheumatoid arthritis.
No, because rheumatoid arthritis is forever. This is self-limiting.
Break by Monday?